Assalamu alaikum. Good morning, everyone. Good afternoon, good evening, actually. It's morning for me and Jabeen, so that's on my mind right now. Welcome to CVU's first 2026 webinar. Dr. Jabeen Fayyaz has blessed us with her knowledge and experience today. For those of you who doesn't know Dr. Jabeen Fayyaz, although she's very famous and in CVU group, Jabeen Fayyaz is she works at the Hospital of Sick Children, Sick Kids. She's a medical director at Sims Kids Simulation Program Learning Institute, medical director, Teaching Scholars Program Learning Institute, co-director of the PEM International Clinical Fellowship Sick Kids, staff physician, Division of Pediatric Emergency Medicine. That's PEM, Department of Pediatrics. She is also an associate professor at Department of Pediatrics at University of Toronto. She's president-elect International Pediatric Simulation Society, IPSS. She's a co-chair of IPSS Inspired PED Simulation Fellowship. She is visiting faculty at many universities, including University of Lahore, Pakistan, and UAG Schools of Medicine International Program at Mexico. Mashallah, you have so many achievements, Jabeen. I'm really happy to know you and learn from you. With that, I will give you the floor. Everyone, please keep your mics muted unless you have a question. And I will be posting a link for the certificates. And this time I added country to the form just so I can assess who is joining from where, so I can add the times for those countries as well. So please help me out with that. With that, Jabeen, the floor is yours. Thank you.
Thank you so much, Sakina, for a kind introduction, and thanks everyone for joining. I see many friends, many colleagues, and in the call. It may be a little bit of repetition for those who have attended the foundational concepts of simulation in the past, but just for the sake of everyone, I hope I am seeing a lot of people who have attended the previous sessions are in there. So I will probably pass on the initial part of my presentation very quickly. Today we are going to talk about like a foundational concept and some of the INACSL standards. I cannot do it all by myself, so I want to acknowledge all the teams that I work every time and all the international collaborators and partners. These are some of my disclosures. And a lot of you do not need that reinforcement, but I always say that traditionally we used to learn about the clinical skills, about the clinical cases as it will come to us. We are working in our clinical environment during our medical school rotation or during our house job or during our residency. And if we are lucky, we get to practice that skill, and that practice is on the patient. At least I'm telling from my era, I know a lot of development has happened now, but when we were trained, there's very, very limited opportunities to practice outside clinical, like actually on the patient. We learn history taking on the patient. We learn IV cannulation, intubation, and all the skills by practicing them on the patient. But now, when I reflect back and I think about it, whether it was a safe thing to do for ourselves as a learner and for the patient being as a patient. So if we have done mistakes, like I remember, I'm not going to repeat that, but I remember we have given a medication in a wrong way and that child did not survive. I don't know whether that is the disease process or that is the, God forbid, the harm that I have caused or we have caused as a team while we were working on the shift on that day. So that is why I think I'm very passionate about simulation, because simulation allows you a venue where you can turn practice into mastery. You are allowed to make mistake. You are allowed to explore new techniques, build your confidence in a controlled environment. You can uniform or unified everybody's experience. Like if I am getting XYZ, every one of us is getting XYZ, rather than it's depending upon what will come up or what will show up during the shift. So I would say simulation has now become, there's no question that why, how. It has now been proved and has evolved as a powerful tool in the ongoing quest of excellence in learning, excellence in mastery, excellence in competency-based education for that has been proven worldwide. So that is what I would say. We at SimKit Simulation Program, this is our Sim Center where we practice, and Raphael is one of our Sim specialists, where we learn and replicate complex life scenarios and foster interprofessional collaboration and interprofessional learning. As we always start with definition, and I want you to be on all of us on the same page. So bear with me, and I will quickly go to some of the definitions so that we can go to the next part. So what is a simulation? As told by David Gaba, who is considered as a godfather of simulation, has given us this definition. And a couple of things I want to highlight here: that simulation is a technique or a tool, not a technology. It is really technology enhanced, but then it is again a tool, again a way to teach or to learn, where you replace or amplify real life experiences with guided experiences in a fully interactive manner. And you act as a facilitator of learning rather than a teacher. Simulation-based learning can be utilized for any skill: cognitive skill, behavioral skill, technical skill, and you can teach them by using fidelity, which we are going to talk in a minute, where you can give them medical knowledge, you can teach them about teamwork, communication, and you can also inform your system and your process for the improvement as well. I would like to remind everyone that simulation educators, as an educationist, we have this basic assumption, and we always hold this basic assumption that everybody participating in the simulation based activities is intelligent, capable, cares about doing their best, and want to improve. And it is very, very important for us to start with this basic assumption, because it allows us to have a mental frame that everybody who is coming here is coming with good intent and with the intent to improve, and they are allowed to make mistake. When we start with this basic assumption, then our lens of seeing their performance will become from the lens of improvement, and our debriefing and our feedback will become from the lens how they can do better, rather than focusing on their mistakes. We just do the same, but here our focus is how they can do better. So this is a little bit of a switch or a change in our mental frame that we have to bring and have to work. And this is from the Center of Medical Simulation, and you can always put it, like I have seen people have put a big posters of this basic assumption. So whoever entering into the Sim Center will read and will understand our mental frame as simulational educationist. Now, quickly going on the foundational concepts: mannequin. Mannequin is a life-size simulator that could be full body, half body. The task trainer, as the name indicate, is a part of the body which is represented by a mannequin to practice task. The difference between mannequin and task trainer is that mannequin are costly, task trainer are less costly. They are more durable, more rugged, so you can practice the skill fail again and again. And it is important for us because if we are doing a scenario where we have to learn about how to manage a septic shock or how to run a scenario for status epilepticus or neonatal resuscitation, then we need a full body mannequin. But if our intent is to teach them how to do an IM injection, how to do a suture, then task trainers are fine. Then this term, which is simulated person, we don't call it standardized patient or simulated patient here in simulation based education, just because that in simulation, they are not only patients who are performing or being playing a role. That is why they are called simulated person, which can portray a patient, can portray a family member, can be a healthcare provider based on the objective of your simulation. Hybrid is any combination. For example, here you see a lady who is a simulated person with a mannequin who is a child. Similarly, in these pictures also a person who is simulated person and a task trainer for IM injection. And here is the delivery where lady is a simulated person and the simulated task trainer is a birthing task trainer. Then comes the virtual reality and augmented reality. Virtual reality, again, if you are sitting here and you do not have any connection of your environment, then it's called virtual reality. Augmented reality, you are still in the environment and the environment get enhanced, then that is augmented reality. And a lot of now focus in the healthcare actually is on augmented reality because you still want some connection with your real environment. You cannot want to detach with your environment, with your patient, which is represented by mannequin. That's why a lot of things are coming up as mixed reality, extended reality, which is a combination of virtual reality and augmented reality. Then again, a very important component or concept is about the fidelity. Fidelity is sometimes misnomered or misunderstood as high technology mannequin. Fidelity is again just a realism. Like you can see the definition, and realism can be enhanced by multiple way and only one way is your mannequin. So it has physical fidelity, which is represented by mannequins, by medications, by the color, by the smell, by the setup of the room. Then the conceptual fidelity is how good the progression of the scenario is. Like how well, if it is a scenario of a pregnant lady, does the scenario proceed in a logical way? If it is a scenario of respiratory distress, then does the respiratory distress is looking like a respiratory distress in terms of appearance, in terms of the vital signs? And the psychological fidelity, which is about the emotional stress, about the anxiety, about the layout. For example, if this mannequin is we are do not have our females like this, so what you can do, you can use, this is just a hair wig, you can use the hair color which is black or brown, which is the color of mostly Pakistani women or any other Islamic culture. You can make them wear scarf, you can dress them with a simple shalwar kameez, which is kind of, or abaya, long gown, that is usual representation. So this is what I meant by the usual psychological fidelity, that the psychology of the scenario, for example, breaking bad news, so people are not laughing or your simulated person is not laughing. Then moulage is the way that will help you in creating that fidelity. And in simple word, it is a makeup. It's a French word which is equivalent to makeup. It will help you in increasing the fidelity. It will help the learner to get the clues. It will engage the sense of vision, sense of like a touch, and it also inoculates some stress. You can do the moulage on the mannequin, on the person, and there are many, many moulage kits which are available. And there are many ways people are doing moulaging. You can be creative, you can use simple household tools to do that moulage, or dress up that mannequin that will represent or will indicate your the or represent, I would say, not indicate, represent the population, represent the identity of your mannequin who is representing your patient. Any questions till now? I know these are very basic concepts, but I just want to put it forward because sometimes we struggle, at least I struggle in the initial of my career, and those who are becoming more and more toward the experience, they already know these concepts. So please put it anything which is not making sense on the chat. And I know I rushed through them because this is kind of repetition for many. I would say this is not the definitions or things that I have made by myself. It is from the Healthcare Simulation Dictionary, and a third edition have been recently launched. This is the barcode, and I will keep this slide for 30 seconds. If you want to keep the scan the barcode and go to the Healthcare Simulation Dictionary. I can tell you all, we all as simulation educator refer to this dictionary all the time so that we all are speaking the same language. And when I'm saying something, you are understanding in the same way. So let it be for 30 seconds and then I will move on. The second thing which I want you all, yeah, thanks, Prof. Dr. Senan. Between usage of simulation or not use in achieving education lecture messages. So if you want some literature, I'm happy to send you the articles. It is not only about achieving the skill, and I'm not saying at all that patient interaction simulation is a replacement of a patient interaction or doing in the patient. The simulation role is creating an experience before they will go to the patient. You can imagine, is it fair that we ask them to do even a history taking first time ever with the actual patient? I know this argument comes every time that we have so many patients, we have so busy environment. So why we give them opportunity to do it with simulation before going to the patient? So there's a huge statistical difference, and these articles are not the recent articles. These articles are from early 20s or late 90s, which have shown the psychological safety of the learner, the patient safety lens have shown it that providing them a simulation based experience have a huge advantage over just taking a lecture. Even the engagement, even the knowledge retention, there's a huge statistical difference. I don't remember the numbers definitely, but I can tell you there's a huge statistical difference, and you can just put in the Google the comparison of simulation based education versus non-simulation or whatever pedagogy you want to compare it, and you will get all those comparison. But I'm happy to share some of the articles in the SIUV group, and you can go through them. Thank you, Habib, for asking. Simulated person and standardized patient. These are interchangeable terminologies. We use in the simulation world simulated patient. Actually, I will say simulated person just because that are is a term that we use just because the confederate or the people do not only always play the role of patients. They can play a role of a mother, they can play a role of attendant, they can play a role of healthcare provider. But if they are playing a role of patient, they are called simulated patients. And simulated patients are necessarily not the patients or not suffering that disease or that particular problem by themselves, but they are simulating it. They are portraying the sign and symptoms. They are portraying the all the history taking, and they have been provided the training to do that. In simple words, you can say actors, which you can argue standardize patients as well, but sometimes they are actually patients and you have standardized them. And this question comes all the time, that what is the difference. These are very much interchangeable language terminologies, but in simulation we call them simulated patients, not standardized patient, because they are not always patients. There are many other roles they play, or they are sometimes healthy people who portray the role of the patient. I hope it get clarified, but you can also go into the healthcare simulation dictionary and read more about it. Thanks for asking. So, as I'm saying, the standards of healthcare simulation standards of best practices, you can scan this barcode. It is a freely available. Anybody can download these standards. They are provided by the Healthcare Simulation Society. They are all followed by healthcare simulation societies, and they are considered as a gold standard for healthcare simulations. They are developed by the International Nursing Association of Clinical Simulation and Learning, which is called INACSL. And there are a couple who are repeated or are revised in 2025. These are the four standards, which are the core standards that anybody who are involved in simulation-based education need to know. And the pre-briefing, debriefing, facilitation, and simulation design have been revised in 2025. And I'm very blessed to be part of the revision process for debriefing. Again, this is the barcode. You can reach out. You may ask this question: why adhere to INACSL standards? It provides you an evidence-based framework, which are scientifically grounded approach for consistent, high-quality simulation experience, and it derives measurable learning outcome. It enhances the engagement because it provides you a structured methodology which will result into the learner's engagement, and then they will be able to achieve the learning objective successfully. And it also make you that it is not developed by you, it is developed by it is being told, or it is not that you are telling them. It is a legit standards you are following, and it will show the organizational commitment. Coming to the very, very basic concept, which is pre-briefing. In simple words, pre-briefing is an information or orientation session which held prior to the start of a simulation activity, in which instructions or preparatory information is given to the participant. The purpose of the pre-briefing is to set up the stage, to inform about the scenario objectives, and to create a psychological safety, and to inform your learner about the basic assumption. So pre-briefing, it happens before the simulation activity to make the learners ready to indulge into the sim-based facilitation. The debriefing, which is a formal, collaborative, reflective process within the simulation learning activity, which happen after the scenario, where you all sit and talk, and we will talk a little bit in detail later on. The simulation-based learning activity is again an array of the structured activities that represent actual or potential situation in education and practice. These activities allow the learner to learn about knowledge, skills, and attitudes in a realistic situation in a simulated environment. As I told you about the pre-briefing, this is a barcode for the newest standard that was just revised last year. It involved preparation and briefing. Pre-briefing ensure that all the learners are now prepared for the educational content or context, and are aware of the ground rules for the simulation-based experience. So there are three phases of simulation-based of pre-briefing phases. It prepare the learner. You have to consider the learner characteristic. Are they only residents? Are they only medical students? Are they combination of interprofessional teams? And then you will plan the objectives of the simulation based learning activities, and then you will ensure that it is met. In the briefing, you will say establish a behavioral norms and expectation. You will articulate the goal. You will describe the learner about the evaluation. You will set the tone, and then in the facilitation, you will discuss, and then you will do answer their question, and you will tell them what is expected. So there are many pre-briefing templates you can get from the literature. This is one of the example of the pre-briefing template that we use at SICKITS. You can see I can go into it. Involved introduction of the learner. You will tell the schedule. You will take a consent. Definitely it's a short, so I'm just telling you the basic heading. If we end up doing our workshops on pre-briefing, debriefing, etc., we will go into more detail. You will provide some instruction, that is what is the background of the scenario, what is this participants, what is the scenario about. You will discuss the ground rules, orient them to the simulator and environment, and then you will tell them what will happen after the scenario has run, and if they have any question, and then you will give them the scenario stamp. There are many other templates are available. You can create your own template, but this is one of the example. It will standardize the pre-briefing for your institute or for the sim-based educators. Then come the simulation design. The simulation design is about simulation-based experiences that are designed purposefully to meet the objectives and expected outcome. We all know it should involve the need assessment, and need assessment involve that what is the need. It is not that simulation is cool, simulation is glittery, so just do simulation. No, there need to be a purpose, there need to be a gap analysis, and there need to be a purpose that why you are incorporating simulation. And then once you have that, then you will make objectives, you will make the simulation scenario, you will decide about the fidelity, you will prepare the environment and prepare your educators, prepare your learner, and then do pre-briefing, debriefing, evaluation. And before all of that, always remember to pilot test your any simulation based activity that you are planning to have. Then as for any objectives, it need to be smart, which I'm very sure as educator you all are aware. It need to be specific, measurable, achievable, relevant, and time based. Now, with the invention of AI, there is a lot of AI chatbots which are being developed to help the educators to develop AI enhanced scenarios. So this is first published in 2023 by two of my very good colleagues, friends, and mentors, David Rojker and Rami. They tested the ChatGPT on developing two scenarios. One is the adult cardiac arrest, and the second is pediatric asthma. The scenario was interprofessional, that is, physician, nurses, respiratory therapists are engaged into this as a learner. They found the strengths that yes, it provide a clear and specific objective. Debriefing plans were given very thorough, well-defined. Simulation standards were adhered. The scenarios were very realistic. Participants' roles and potential challenges were outlined. Dosing guidelines were provided. The pediatric cases were also as robust as the adult, but the areas of improvement were provided. There was a lack of performance branch patient state progression, that what will happen if they have done this action versus they have not done this action. So that was not very good. Some objectives were not time bound, medication doses were inaccurate, then current guidelines sometimes were referenced wrong, not all essential equipments and supplies were included, and references of the scenario or case were not good, and adult cases may be too advanced for the audience. So this is kind of two when they compare that what are the strengths, what are the area of improvement. But yes, it did a pretty good job. And then with the AI now, another thing which is coming up is how you can enhance the visual appearance, or tell them rather than telling how the patient is looking, you can tell them how the patient by a picture or by a chat GPT generated avatar. So you can see now you can the mannequin look like this all the time, whether it's happy, whether anxious, whether sad, whether have a respiratory distress, whether looking pale, it looks the same. But with the pictures generation, you can show on your tablet that this is how the patient look, or this is how the patient look. Even you can create some kind of GIF, which is GIF, GIFs, which are not still images or even videos. So what I want to provide you is the scenario development chatbot, which is developed by Indiana University. David Roger is and his team, and he's very kind to provide the access to all of us, so you can use that. But again, remember, it always need to be confirmed by a human educationist. It's not that you develop the scenario and now it is ready to be used. So I will stay on this slide for 30 seconds for all of you to scan the barcode and have downloaded the chatbot. I wish we have more time, but we will find out some time where we can have a workshop or a session on AI associated chatbots, because the other ones are also developing, which can provide you feedback on your debriefing, which can create some chatbots where learner can interact with the chatbots, and they can not replace, or I would say reinforce and augment your learners interaction with the standardized patients, and they can prepare just in time for their themselves for their interaction with the simulated participant or standardized participants, or simulated patients or standardized patients. Please let me know if once you have like scan this barcode. It will take you to a IU Bloomberg something, and you can pin that on the side of your chatbot. You do not need a paid version. You can put it what kind of scenario you want to develop. It will give you, it will ask you a lot of questions, and once you have answered that, then it will provide you the scenario.
I posted the links on the
Yeah, thank
chat too.
you. And I will post the links in SIUB group as well. Or there's a recorded version available that you can use later as well. Okay, no problem. You can take it, you can listen to it and watch it later on, the recording, and then you can try it. So then come the after pre-briefing scenario design. Always remember, debriefing is the next step, which is learning conversation between two or more people occurring during or after a simulated event that involve reflection on performance, identification of the performance gap, exploration of the rationale for behaviors, and seeking solution. So the debriefing has three components. That is, you will sometime you provide feedback, which is a very facilitator led. You will debrief, which is bi-directional, learner led, and then you will provide a guided reflection. For facilitation is again a process which guide the participants to work together, to comprehend learning objective, and to develop a plan to achieve the desired outcomes. And remember, we are always a facilitator of learning rather than teacher who are teaching them about something. So this is about basic concepts and Excel standards. Sometimes it always comes why use simulation, which I heard from this group as well. Why use simulation? Because it provides you a risk-free environment. It engages the learner. It allow the learner to do mistakes and to learn from mistakes. It provides you opportunity to do sessions together with nursing, with respiratory therapists, with social worker, with other professionals background like emergency with ICU, emergency with general surgery. So interprofessional collaboration and interprofessional teamwork. It improves critical thinking, clinical judgment. It allows you to learn about communication. You control the types of patient experiences and you will uniform their learning, and you can observe the participants more closely and provide more direct, more dedicated, or I would say precision learning concept. Like you will carve the learning for the learner based on their needs. So I would say think of simulation as a sandbox where you can play, you can make things, you can break things, and then decide which one is the best that you want to keep. So you make or carve your learner what you want them to be when they go to the clinical environment. Choosing the type of simulation, you need to answer at least these 5 questions. What is the expected learning outcome? Which type of simulation matches best with the learning objective? Do I need to immerse my learner or they are practicing only discrete skills? What are the level of my learner? What are they capable? And then choose the what best support the learning objective, learners, and what in the available resources. So these are at least ask yourself. It's not that you have to develop new curriculas. You have to replace everything with simulation. Simulation is not the solution for every problem. Yes, simulation, you can see what are the existing gaps are and where you can fill those gaps with the simulation. So I would say rather than replacing or bringing or developing, integrate simulation into your institutional educational cultures or institutional curricula by asking these questions: that what is the simulation institutional program or sorry institutional problem you are trying to address? How much does it cost? How much this intervention is expected to take? What are the learner's expectation? How will you know that intervention is effective? That how you are going to evaluate, and how will you communicate to the stakeholders? What is the return of investment that I will get out if I apply simulation based pedagogies, and are the resources available for that, or am I ready for that? Am my learners are ready for that, and my institution is ready for that? So these are the practical questions you should ask. Then another thing which comes again and again is what is the difference between simulation program and sim center? I have heard it again and again. We do not have a sim center, so we cannot do simulation. That is not true. Simulation program, that is doing simulation, is completely different from having a sim center. So what is a simulation program? Simulation program is a structured educational initiative which is a comprehensive framework that will provide you or that how to incorporate simulation based experiences into the educational curriculum. I apologize, initiative is 2 time. And then the focus is learning objective, which is to meet the targeted learning outcomes, to improve the clinical skills through evidence-based methodologies. And then you will integrate into the curriculum, integrate into the faculty development, and integrate into the learner assessment processes. While the sim center is a physical infrastructure which will provide you the place, the equipment, the technology, the human resources. So it acts as a resource hub and it act as a place where which facilitate you for technology integration. So the key differences is program will help you with the educational content, instructional design, and delivery methodology. But center would provide you infrastructure. So you can still have a program without having a sim center. But yes, the sim center provide you more infrastructure, will make you more standardized. But if today I decide that I want to implement a particular educational program into my curriculum, I necessarily always do not need a sim center. But yes, when those programs are more established, I want to standardize them along across the institutes or across the bigger programs, then probably having a sim center make me more resourceful. So I would say that important myth to debunk here is that simulation is costly, so I cannot implement it. Yes, it is costly, but when then what is the cost of the failure? So look at the WHO program, which is helping baby breathe, which is about from a very basic mannequins, which are filled with water, and now it has been implemented into 80 countries with an impact of, there's a recent article which is published in NEJM, you can see it, which has reduced the mortality up to 50% and the misclassification of fresh stillborn by up to 25%, which is huge and which has been done with a very limited resources. And similar concept we have applied at Indus Hospital Health Network with the help of the team. Adil Khatri is the lead of that project. They approach this with creativity and innovation. And there's a Urdu word, we call it jugar, which is English, the meaning of or English word for jugaad is hack, and they come up with kitchen items, and they created that these are defibrillator, these are the hands, they don't throw up their empty medication bottle, they use it for simulation. This is the cricothyroidotomy model, which is created by simple kitchenite items. This is a chest tube model, which is developed from laundry basket. This is a lateral canthotomy model, which is developed from the a paper like a paper cup and the golf ball. This is a pajama model, which is created for delivering and by using simple dolls, as well as this is a lumbar puncture model, which is used for develop. These are the home clips that are used to dry up your clothes, put it on there. Then these are some of the mollages that have been created. They even created a central line ultrasonographic model, and they are still doing these cost effective solutions. And this is the amount of training that have been achieved, and we are able to teach almost 500 IPE teams with the help of local and international facilitators. So it is doable. They don't have any sim center or any resources. There's only very small seminar room. On that room, this all has happened. So I just want to give you an idea and tell you that it is still possible. I have some of the learning theory, but I know we don't have time. So I'm skipping that because I want to tell you about our SimKit simulation program. And you have this barcode and you can scan it. And anyone who are visiting ever in Canada are more than welcome to visit or tell me, reach out to me, and I can organize a visit for them at our Sim Center. Our Sim Center, and we don't get it now. We have the Sim program from 2019 to 2009, and we only get the Sim Center in 2023. Before that, we used to have a 1600 square foot Sim space with a one room, which is we used to have as a high fidelity room, one procedure room, and one a debriefing room. And after doing so many years of simulation, we are able to show the importance or return of of investment for our sim program, and that's why we got this funding and we are able to get this big sim center, which is now 11,500 square foot sim space with a state of art simulated suits, which are high fidelity, debrief brief room, assessment room, sim kits invention lab, where we create our own task trainers. So these are the pictures of some of our sim spaces. These are the mannequins. We always believe on functional fidelity. So you are not seeing the mannequins which can blink, which can talk, which can walk. Even we have mostly like some, we do have a high fidelity mannequin, very few, but most of them are mid to low fidelity. We offer faculty development programs like various workshops, which are all in person, and we do the consultation for simulation development as well. If you want to develop any scenario, tabletop exercises, in situ space evaluation, or development of new spaces like new hospitals, new revamping or redesigning of the spaces. We have this light program, which is Learning Institute Teaching and Education, where we do offer electives, which is from 2 to 12 week, a certificate course, which is 3-month program, and a fellowship. They are all in person, and they are all focused on simulation, and they are all for every professional background. I know you will say, oh, we are pediatric hospital, but simulation skills are very transferable. So we have nurses that have come, we have surgeons that have come, we have respiratory therapists who have come and have benefited from these programs. So if you want to know more details, you have the barcode and you can get to know. We are also practicing a lot of technology, which is AR, VR, AI, immersive rooms, and highlights. You can see the highlights, but a lot of focus is about patient safety, that how can we improve the patient's related processes, how can we make the our spaces more patient geared. So it's a lot also happen in the area of patient safety, which is now being called as translational simulation. If you have heard about it, that how the learning that we have provided to our learner is translating into simulation based education. These are the number of our learner sim program utilization, as well as they are interprofessional versus intraprofessionals. And this is all our SimKids team, which has grown over time. When this program was started, there are only 2 or 3 people who are part of this team. So if you want to know more, you can scan this or follow us on our LinkedIn. No, it's not pediatric. As I said, it is. That's why it does not have a fit program. If you reach out to us that I want to come for elective, then our team will do meet with you, ask your learning objectives, ask your what you want to achieve, and will dedicatedly carve that experience for you. Yes, you need your own funding for coming, so that is a one caveat, because it is non-clinical and it is sim based. So you need your own funding, or your institute can sponsor you. So follow us on social media, LinkedIn, and stay tuned or stay connected to know more and more. And as a president of our International Pediatric Simulation Society, I would like you to explore and join. For low middle income countries, it is free to join. And again, you will ask me the question that it's an International Pediatric Simulation Society, but in any way you are involved in PEDS, you can join. For example, anesthetist, if you do anesthesia in PEDS, you are eligible. If you are surgeon, but you do pediatric surgeries as well, but you are journal surgeon, you are eligible to join the Pediatric Simulation Society, because again, it is a simulation society, and it will and give you about simulation that can be used for more broader application. It will not give you, there's no difference in applying simulation principles to peds, to surgery, to adult, to journal, internal medicine or family medicine. Simulation based pedagogies are same and the principles are same. So you can join. These are the benefits of being the part of the IPSS. And then we do have an academy which offer many, many courses. And we do offer fellowship, which is a online distant fellowship. It is research project based fellowship, and you do not have to pay for anything for that fellowship. If you are selected, then you will get funding for, and you will be assigned mentors to complete your research project, and you will be provided funding to attend one of the conference to present your studies. There's a virtual component of this also, of the conference that you can join. And our in-person conference is in Rome this year in 2026 from 4th to 7th May. And the late breaking abstracts are open. If you are involved or doing anything in simulation, please submit it, and in that way you will be able to join. So this is what I want to tell you about the basic concept. This is my email address, my LinkedIn page. Connect with me, email me, and I will provide you more and more information about a lot of things that I have talked about. I just want to give you a sense, journal sense, and these are some of my references. But I'm just going back to this slide so that you can take a record of my email address, and you may be able to join my LinkedIn profile as well if you are already not a connection. I know there are 5 minutes now. I can now take some of your questions. As I have already answered Professor Sinan question that it is not only pediatric, and for the sick kids simulation, which is where I work, it is in Toronto, Canada. For the IPSS Inspire Fellowship, it is a distance or a virtual fellowship, but it is research-based fellowship. It is for mid-level career simulationist, not early or experienced simulationist. Yes, please, Professor Sinan, please go ahead, unmute yourself, and I'm happy to clarify or answer any of your questions.
Thank you, Dr. Jabeen. Although you have answered all my inquiries and questions. However, you mentioned that these are all funded, but at the last you said this mid-career simulation, not early. Or so who could stratify us as early or mid or advanced?
Yeah, thank you
And this
so
is
much.
one. And the second one, sorry, who can fund it? So from your institute or our institute? Thank you so much.
My pleasure, and thanks for asking this question. If you do not know anything about simulation, then I'm talking about two fellowships here, two programs here. One is the Light program, where my institute, which is at my institute. For that, you will require your funding, and any person, anyone can apply, because it is about telling you about simulation based education. It doesn't matter whether you are very novice, you are experienced, you are advanced, you can come, you can get a hands-on experience, you can work with our sim team in our sim center. For that, you will require your own funding. This is one bucket. The other bucket is through IPSS, which is International Pediatric Simulation Society. The requirement is you need to be a member of the IPSS, and for that you need to be a mid-career level, because why I'm saying it will not tell you what is simulation, it will not teach you about simulation, it will not give you, it is a research-based fellowship. So you need to know the basic know-how of simulation, and you need to have a research project to apply for that fellowship. So it is a research project based fellowship. That is why I said you need to have some information about simulation. and you need to formulate a research project. And based on that research project, you have to apply for IPSS Inspire Pediatric Simulation Fellowship. And for that, you do not need funding. You will be assigned two mentors, and you will be given funding to attend the conference and to present your research. So it's very difficult to delineate who are novices, who are experienced. So you can imagine that much experience that is required to do a research-based project in simulation. That is what is the definition of not being novice and being experienced. I hope I have clarified that, Professor Sanan, for you.
Yes, thank you so much. Thank you.
My pleasure, my pleasure. Any other questions? And Saima, I know you have listened me multiple time telling all these things. I hope you have still learned something new. It may have refreshed your memories, and it provide couple of new tools to you still. I know at that time the AI scenario development chatbot was not there. So probably that is something new you may have taken from this today's session. I will again say, please fill up the form. As Sakina has mentioned, she only get 3 names for the certificates. So please fill up the form, provide your names, and also provide your time zones so that timings can be mentioned on the subsequent sessions. And your names are correct on the certificates.
Thank you, everyone, for joining. Thank you so much, Jabeen. I really enjoyed. I have no medical background, but I really enjoy every talk that I am part of for CVU. And I'm thankful for CVU for giving me this opportunity. Inshallah, our next session will be February 7th. It'll be a fire chat between Dr. Shabi Zaidi and Dr. Azra Raza. And the topic will be finding the first cell, a conversation between the knife and the microscope. So please don't miss out. I'm excited and I can't wait for February 7th. And I'm sure you feel the same way. And see you all again in 2 weeks. Thank you so much. Appreciate you coming.
Yeah, thank you so much, everyone, for participation, spending your time with us. Take care. Bye-bye. Assalamu alaikum.
Walaikum salam.